We'll go ahead and get started. Hello, everyone. Thank you again for joining us this week for the weekly Wednesday webinar series. We will take just a moment to let the room fill up, and then we'll go ahead and get started. I hope you're all having a wonderful week. Alrighty. Well, good afternoon. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on red blood cell transfusion in sickle cell disease. My name is Alsa Murtha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. We do have an announcement for you today. We are excited to share with you that the Partners in Bleeding Disorders Education Program is launching a new training program in classical hematology for early career physicians. The Partners Physician Academy is a US-based bleeding disorders focused educational program delivered by hematology experts. The program's goal is to support and accelerate career advancement of physicians in fellowship for those early in their career for leadership as part of the HTC network. This 5-day training course will take place September 12th through 16th, 2022 at the Alexander Hotel in downtown Indianapolis, Indiana. Participants are expected to arrive in Indianapolis on September 11th and required to attend all days. The Academy agenda will include topics on the national landscape and HTC professional organizations, overview of hemophilia, topics you may have not learned in fellowship, VWD, novel therapies, clinical research, and rare disorders. The Partners Physician Academy will cover costs for each candidate selected for attendance, including air travel to Indianapolis, ground transportation, meals, and coffee breaks during training, hotel accommodations for 5 evenings, planned evening activities in Indianapolis to support networking with mentors and colleagues. Attendees will need to cover out-of-pocket expenses during travel and any incidentals during the hotel stay. Eligible candidates should be a 2nd to 4th year fellow or early physician up to 2 years post-fellowship, currently seeing patients in the field of bleeding disorders, working or intending to work as part of the US federally recognized HTC network, and able to attend the entire academy the 12th through the 16th of September. If you are interested in attending, you can check out the link posted in the chat. I'll go ahead and throw that up in just a moment. Applicants will need to submit a current cover letter and nomination form, and they should be received by July 8th, 2022 for consideration. Inquiries regarding the Partners Physician Academy should be emailed to partnersphysicianacademy@ihtc.org. I'll also include that in the chat for you. So at any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, June 24th. I am joined today by Dr. Sally Campbell-Lee. Thank you for taking the time to join us today. I will go ahead and turn it over to you to get started.
Thank you very much, Alison, and thank you to the NHF for inviting me to give this lecture today on red cell transfusion in sickle cell disease. So I'm going to talk about the indications for transfusion, the mechanism of transfusion, either by automated red cell exchange versus simple transfusion, and also we'll cover red blood cell alloimmunization. So as many of you know, sickle cell disease is an inherited disease. It's caused by a homozygous mutation in the beta-globin gene that results in the substitution of a single amino acid. This results in a spectrum of disease. There is hemoglobin SS disease, sometimes referred to as sickle cell anemia, but there are also multiple other types depending on the additional mutations that may also be seen. So we typically see SS here in the United States, but there's also SC, S beta 0 thalassemia, and S beta plus thalassemia, as well as some other types. One of the things that practitioners and those who treat this disease need to be reminded of is that this is a chronic hemolytic anemia. Everyone always focuses on the vaso-occlusion, the rigid sickle-shaped red cells, including vessels, but that's really not the only thing that's happening here. This is a chronic, there's chronic hemolysis, chronic destruction of these patients' red blood cells that does lead to the vaso-occlusive painful crises, but as well as that, there's also significant end organ damage that also occurs because of the chronic hemolysis. There are about 2,000 births annually in the United States impacted by sickle cell disease, and there are about 100,000 affected individuals. So this is a cartoon that demonstrates just what I was mentioning in the previous slide. In a vaso-occlusive crisis, the sickle red blood cells and other inflammatory mediators actually induce activation of the endothelium, which is the cells that line our blood vessels. The damaged and stimulated endothelium then is poised to actually recruit white blood cells. E-selectin, which is a marker on the endothelium that interacts with some of these signals, actually ends up helping to generate additional signals, which causes a polarized expression of MAC1, which if you have the close-up here of the cartoon, and what this results in is neutrophils that basically kind of crawl along the surface of the endothelium, which allows capture of the circulating red blood cells, which are sickle-shaped here. And this is what culminates in vaso-occlusive crises in the post-capillary venules. So it's an inflammatory situation that results in the neutrophils becoming activated, moving along the endothelium and sort of helping grabbing these red cells, which leads to clustering and vaso-occlusion. So with all that in mind, transfusion is a key component of therapy in sickle cell disease. And I like to think of this in terms of one of my favorite movies, The Good, the Bad, and the Ugly. The good things that transfusion does is it improves oxygen carrying capacity, just as any other red blood cell transfusion does for a patient. That's really the only reason to give a red blood cell transfusion is when you need to increase a patient's oxygen carrying capacity. However, in sickle cell disease, one of the other good things transfusion does is it decreases the blood viscosity. And chronically transfused patients, it suppresses production of the sickle red blood cells because of the increased tissue oxygenation, which is the main driver for bone marrow production of red blood cells. Of course, with transfusion, if you do a lot of anything, you can get bad outcomes. And with that includes red blood cell alloimmunization, where patients have an immune response to foreign blood group antigens, as well as autoantibodies. People make antibodies against their own red blood cells. The ugly things that can happen as a result of this are, of course, delayed and acute hemolytic transfusion reactions, as well as something called bystander or hyperhemolysis, which can actually be fatal. as can hyperviscosity, which can occur when red blood cells are transfused too many or transfused too rapidly. And then long-term consequences of a large volume of transfusion, depending on the manner in which it's given, also includes transfusion-related iron overload, which also results in end organ damage, particularly cardiac and endocrine and liver system. So because of this, it's important for us to remember that patients should only be transfused when the benefit outweighs the risk. I mentioned red blood cell alloimmunization and acute and delayed hemolytic transfusion reactions, as well as iron overload, but we still need to also remember there is transfusion-transmitted infectious disease. Over the past 20 years, we have really made a dent in the risk of HIV and hepatitis C occurring per each transfusion episode. We're down to this being about 1 in 1.2 and nearly approaching 1 in 2 million based on the models that are used to calculate this risk. And what this number means is that it takes just over 1 million transfusions for a patient to encounter a donor who has tested negative for HIV or hepatitis C, but is actually positive and capable of transmitting the disease. So this has become a exceptionally rare event. There has not been a case of transfusion-transmitted HIV documented in the United States for close to 20 years. So the indications for transfusion in sickle cell disease include those that are episodic indications, meaning just at the time of the complications occurrence, as well as chronic transfusion, where patients are put on generally a monthly, once every 4 to 6 week schedule of transfusion. So indications for episodic transfusion include preoperative, whenever a patient with sickle cell disease is going to receive general anesthesia. It's best to make sure that their target hemoglobin is at least 10, and the portion of hemoglobin S, the amount of sickled red blood cells, is less than 30% at the time they get general anesthesia. And this helps to prevent complications that can occur, which include acute chest syndrome. During acute strokes, it's also, transfusion is an important part of therapy here. It's important that transfusion be given to patients that are having strokes caused by sickle cell disease as soon as possible after it's been recognized and diagnosed. Aplastic crises, splenic or hepatic sequestration, and multi-organ failure are also important indications for episodic transfusion. We have a lot of data that shows that chronic transfusion is plays an important role in preventing not only recurrent stroke for children who've had previous strokes, but also prevents the first stroke in children who have elevated transcranial Dopplers, which show evidence of cerebral vasculature that increases their risk of stroke. Chronic transfusion has also been shown to reduce the recurrence rate of acute chest syndrome. There are a number of complications of sickle cell disease that are listed in most textbooks as reasons for no transfusion. And they specifically list uncomplicated painful crises as something that is not a suggested indication for transfusion in sickle cell disease. Generally, this is because there is low quality evidence that shows that there is benefit. The other issue here is many practitioners feel that transfusions shouldn't be given in this setting because it's another exposure that could lead to red blood cell alloimmunization, which will make transfusion difficult when there are documented, well-founded reasons to give blood. However, this is something that probably bears further investigation. There was a study published in the journal Transfusion looking at the relationship of simple transfusion, where we're just infusing 1 or 2 units, with 30-day readmission rates in patients admitted for vaso-occlusive crises. And in all admissions, including those patients with a high risk of readmission, so these were patients receiving opioid therapy on admission and with chronic cardiac, kidney, or liver disease, admissions where there was an intermediate risk of readmission, and admissions where there was a low risk of readmission. And across all types, patients who received blood transfusion actually had a reduced 30-day readmission rate. So we need to design trials to evaluate this, not just with retrospective data, but we are going to need to obtain prospective data from well-controlled studies evaluating this. So one of the indications I mentioned in the previous slide that is a well-founded indication for transfusion is stroke. About 8% of children from high-income countries, such as the United States, will have a stroke by age 14 without any intervention. It is even higher in lower-income countries. Acute stroke, there's data that shows that red blood cell exchange, so when the transfusion is given through an automated system that I'm going to talk more about later, is superior to giving transfusion just by simple transfusion of infusion of 1 or 2 units. And that's likely because during a stroke, we need to improve the patient's hemoglobin to 10 grams per deciliter, and it's important to rapidly reduce the proportion of circulating sickle red cells to less than 30% to prevent further neurologic damage. There are a number of studies that show chronic transfusion prevents stroke. The hallmark study is the STOP study that was published in the late 90s. This was a randomized controlled trial of red cell transfusion every 3 to 6 weeks in children who had elevated transcranial Dopplers. So these children were at risk for stroke. And they showed that the children that were placed on a transfusion protocol had a tremendously reduced risk of stroke. It was a 92% relative risk reduction with transfusion compared to the group that received standard care. The study was stopped early because of this data, and this therapy is now widely provided to patients that have elevated transcranial Dopplers as a result of this study. And it's prevented strokes. One of the problems with chronic transfusion in this setting, though, is it's not clear for whom or when you can stop transfusions, particularly as patients mature to adulthood. In follow-up data from the STOP study showed that within 4.5 months of stopping transfusion, 34% of the patients reverted back to having elevated transcranial Dopplers, and 5% of these patients actually had strokes. In patients who transitioned from pediatric to adult care who had actual prior strokes, 30% of them who stopped 36% of them who stopped transfusion after transitioning care actually died. The Twitch study, which looked at children who had abnormal transcranial Dopplers and no severe vasculopathy, and also no prior stroke, showed that these patients could be safely switched to hydroxyurea, which increases the proportion of fetal hemoglobin, from transfusion. So this is one group that can it's been shown it's safe to transition them to medication from chronic transfusion. The other indication for red cell transfusion and sickle cell disease is in acute chest syndrome. This is defined as a patient who is diagnosed with a new infiltrate on chest X-ray, who has respiratory symptoms such as shortness of breath, tachypnea, cough, is hypoxic, and also has chest pain and perhaps fever. The cause of this is usually maybe multifactorial, but the underlying pathologic thing that is occurring is acute lung injury, usually secondary to infection, pulmonary vaso-occlusion, or fat embolism. And this is actually a leading cause of death in adults with sickle cell disease. So the schema I have here on the right-hand side of the slide shows that this can start off as a vaso-occlusive crisis, but you can get cascading effects, particularly even where you've got therapy-induced effects like opiate-reduced respiratory depression, and this can lead to hypoventilation, atelectasis, the adhesion, thrombosis, and vaso-occlusion, similar to what I showed in the earlier slide, can result in pulmonary infarction, and the infection can also add to all of is a just an additive effect here. These all can lead to decreased oxygen delivery and hypoxemia, which is where red cell transfusion plays a role in treating acute chest syndrome. The NIH study group actually recommends exchange also in this setting wherever it's available, particularly where there is multiple pulmonary lobe involvement, rapid progression, and severe hypoxemia, along with antibiotics, oxygen therapy, hydration, and pain control. Chronic transfusion on a regular basis has been shown to reduce recurrent acute chest syndrome. The STOP data from the STOP trial also showed that there was a reduction in episodes of ACS in children who are being transfused for stroke prevention. Many centers now use hydroxyurea instead of transfusion for the production of recurrent acute chest syndrome in adult patients who are eligible for this. And it has been shown to reduce acute chest syndrome by 30% and transfusion utilization by, it reduced acute chest syndrome by 50% and transfusion utilization by 30%. So the other thing that is important to note here is how the transfusion is administered also appears to be important. Simple transfusion is best to use when your patient needs increased oxygen carrying capacity, but you don't need to rapidly reduce the percentage of hemoglobin S. So if you've kind of got a borderline hemoglobin S percentage of 40% or so, that patient may not need an automated red cell exchange, if they're anemic enough to tolerate the addition of the transfusion just through simple transfusion, that may be enough. However, one of the drawbacks here is volume overload, particularly if you have a severely anemic patient with a increased plasma volume and underlying cardiac dysfunction. They're at increased risk for volume overload. Transfusion-associated volume overload, or as some refer to it as TACO, TACO, which is transfusion-associated circulatory overload, is actually the #1 cause of transfusion-associated fatalities in the United States. So it's important to evaluate patients' volume status prior to proceeding with simple transfusion. The other thing that simple transfusion places patients at risk for is hyperviscosity, where if you have blood that is given too rapidly, can actually be fatal. Red cell exchange removes the hemoglobin S red cells and rapidly replaces with red cells from donors who have normal hemoglobin, hemoglobin A. We can decrease the percentage of hemoglobin S to less than 30% without increasing the volume And it also reduces the rate of iron accumulation because we're not just adding red cells, we're also taking off red cells and the attendant iron associated with them. The drawback of red cell exchange is theoretically there's a greater risk for alloimmunization because you have more donor exposure. There is also a requirement for good vascular access. We can't use butterfly or small gauge needles with red cell exchange. You really need to have in a patient who's got peripheral access, they've got to tolerate placement of two large gauge, steel angiocath needles for the duration of the procedure. And those are rare adult patients as their vascular access, peripheral access tends to fail in this patient population. So they typically require placement of central access, and it has to be basically the type of access that you could dialyze through. So a rigid large bore, at least dual lumen catheter has to be placed. So when you have a situation where a patient might benefit just from simple transfusion, the transfusion of hemoglobin A red cells reduces the effects of sickling and increased blood viscosity and increases oxygen delivery. As I noted before, it's important to prevent overtransfusion. When the starting hemoglobin S is greater than 60%, simple transfusion can actually lead to a marked increase in viscosity. When the hemoglobin S is about 40%, simple transfusion has a minimal impact on increasing viscosity. When hyperviscosity occurs, it can present as hypertension, convulsions, and if transfusion is rapid, it can result in cerebral hemorrhage, which can be fatal. So red blood cell exchange is an automated procedure that rapidly reduces the proportion of hemoglobin S containing red cells. We're removing sickle red cells, replacing with normal red cells, and rapidly decreasing the percentage of hemoglobin S to 30% without increasing volume. This leads to more donor exposure. So it can lead to alloimmunization, and as I mentioned before, the vascular access issue. To provide red cell exchange is, in addition to the equipment, this is a picture of the Spectra Optia machine that's made by Terumo, which is the equipment that's most widely used in the United States for automated red blood cell exchange. It also requires a physician staff that's knowledgeable in how these procedures are managed and particularly complications of the procedure, as well as the how the machine settings need to be used for this procedure. It also requires a nursing staff that has been trained in the operation of the machine, as well as care of patients with sickle cell disease. This means that this procedure is not widely available around the world and is not even available in all areas of the United States either. So as I mentioned before, the automated red cell exchange is a machine that's called a blood cell separator. In the United States, this is FDA approved specifically for the indication of sickle cell disease treatment. The machine provides isovolemic removal of the sickled red cells and replacement with the hemoglobin A donor red cells. So we calculate a volume of red cells to give based on the patient's gender, height, and weight, their starting hematocrit, and the desired end hematocrit, and what we refer to as the FCR, which stands for fraction of cells remaining. So that is what the nurse inputs to tell what proportion of the patient's red cells to remove. Typically, the volume of red cells we're using is somewhere between 5 and 10 red cell units per procedure. My the house staff at our hospital, if we need to do a red cell exchange in the middle of the night, sometimes they'll call us and go, "Oh, Dr. Campbell, I ordered 2 units for you guys." And my response is, "Thank you for trying to help. I appreciate that, but we actually need like 12." And people's eyes will get big because they don't realize how many units that we have to use for these procedures. As I also mentioned before, vascular access requires the draw, so to pull the blood into the machine, and access for return of the patient's plasma, white cells, and platelets mixed with the donor red cells. So we're going to need to place either 2 large bore peripheral access, and by large bore, 16 to 18 gauge needles, or a rigid dual lumen central line. Alternatively, many of our patients, those on chronic red cell exchange, there's implantable ports that are available. There's a vortex port, and BARD also makes a port that's made for chronic pheresis access. However, the BARD port it's a single lumen port, so you would have to place 2. Alternatively, for some patients, if they've got that one good peripheral vein, we can use that as return. And there are some patients that have elected just to have a single BARD port placed that we use as access. The procedure also requires citrate anticoagulant. This is the anticoagulant that's part of the anticoagulant preservative solution of the red blood cells themselves. This is what keeps them from clumping. However, we also put this into the machine circuit to prevent clotting of the patient's blood in the tubing, in the machine's tubing. One of the side effects of this is citrate works by lowering the ionized calcium. That's how it prevents clotting. And this can cause symptoms in the patient if their ionized calcium gets too low during the procedure, tingling, numbness, particularly in the small muscles, because calcium is also important in muscle contraction. But if that is left untreated, it can also cascade to cardiac arrhythmias, which will present as hypotension. So we give calcium replacement in the return line to prevent citrate toxicity and overwhelming symptoms during this procedure. Most patients tolerate this very well. We have a clinic where we perform a large number of these procedures on an outpatient basis. But that said, patients still require monitoring during the procedures. So when we talk about how the transfusion is given, we're either going to give you 1 or 2 bags for a simple transfusion, or perhaps what looks like a tray of blood from the blood bank for exchange transfusion. So you've heard me mention red blood cell alloimmunization. What that means is, to back up a bit, most people know when we talk about blood types, they'll say I'm A pos, B pos, O neg, what have you. That's really only referring to the ABO and the RHD antigen typing. There are actually more than 400 blood group antigens outside of ABO that have been described. For most patients, we only routinely need to match red blood cells for the ABO and the D antigen of the Rh blood group. But the Rh blood group actually includes, we're bordering on 60 other identified antigens besides D. And so because these are antigens they're either carbohydrate antigens like the ABO blood group, or proteins, Rh, and in the cartoon I have here, other protein antigens that we deal with are KID, Duffy, Cal. People after transfusion or pregnancy, people can have an immune response. They can make antibodies to any of these blood groups. Overall, after transfusion of red blood cells, the frequency of sensitization is somewhere between 2 and 5%. So it's relatively low. Most of these blood group antigens are not very immunogenic, and most people's immune system are going to ignore them. However, some patients, this small portion do make antibodies, And once that happens, if they're exposed in future transfusions to red blood cells that express the antigens that they become sensitized to, they're at risk for having more commonly a delayed hemolytic transfusion reaction that can happen a few days to several weeks after transfusion and is usually not fatal. However, in some instances, they are at risk for having an acute hemolytic reaction, which occurs either during or directly after transfusion and can be fatal. So because of that, all future red cell transfusions have to be negative for the antigens the patient has become sensitized against. In many instances, this doesn't make it that much more difficult to find blood for the patient. However, if they have become sensitized against antigens that are commonly expressed in the donor population, it can become difficult to find compatible blood for these patients, and we may have to embark on a multi-state search for compatible blood for some patients. So this phenomenon leads to therapeutic limitations due to procuring compatible red cell components when it does occur, particularly against commonly occurring antigens. I mentioned overall, it's 2 to 5% of all patients who get transfused. However, because of the volume of red blood cell transfusion that is used to treat patients with sickle cell disease, somewhere between 30 and 50% of all patients who have sickle cell disease have antibodies against foreign blood groups. There are some retrospective studies that show that once this occurs in patients with sickle cell disease, they're actually at increased risk for death. There's a correlation between red blood cell alloimmunization and an increased risk of death in these patients. So because of that, it's important to have a better understanding of patient risk factors and the immune mechanisms that cause this that could lead to preventative strategies for these patients because of the importance of transfusion for them. Why do these patients become alloimmunized? Well, the biggest factor is the differences in frequency of red cell antigen distribution between our largely Caucasian donor base and the mostly African American and Latino patients that make up the sickle cell disease patient population in the United States. So if you look at the chart I have on the right-hand side, various commonly clinically significant antigens that occur on red cells, like, for instance, Big E, which is part of the Rh blood group. 70% of Caucasians are Big E negative. However, 79% of African Americans are also Big E negative. Anti-Big E is the most common antibody that we see all patients make, including sickle cell patients make, after transfusion in those who are going to make antibodies. So what's interesting to note is that the antigens that have the largest disparity are actually not the most are not the most common antibodies we see. So for instance, if you look at Duffy A antigen, 35% of Caucasians are negative, 90% of African Americans are negative. That means in an African American patient, there's a very good chance that that person lacks this antigen on their red cells. And if they get a red cell transfusion, there's a very good chance they're going to be exposed to this antigen. But that's not our most common antibody. The most common antibodies are actually the Rh, Big C, and Big E antibodies. And the other most common antibody is Cal. The other thing that we've noted is that even with ethnic similarities between blood donors and recipients, there's still a high rate of alloimmunization in patients with sickle cell disease. So in a study of Kuwaiti Arab sickle cell patients, those who received ABO and D matched red cells, which is the traditional matching for transfusion, 65% of these patients developed antibodies to foreign blood groups outside of ABO and D. And in those who received red cells that were specifically matched for these antigens, only 24% had antibodies after transfusion. However, that's still quite high. So what is the reason for that? So we know greater transfusion volume generally increases the risk However, there have been some studies, and this is not the only one, but this is one that I have here as an example. They looked at pediatric patients with sickle cell disease that were on a chronic transfusion regimen. They received leukoreduced, ABO and D matched, as well as RH and KEL matched red cell transfusions. Patients who had antibodies to other blood groups got red cells that were matched for those antigens. And when they looked at the patients that were receiving simple transfusion, their alloimmunization rate was actually higher than in the patients that were getting their transfusions by red cell exchange. And it was the difference was statistically significant. People have also tried to look at HLA phenotypes. There was an early study that showed that there was a particular propensity, there's an association with increased alloimmunization in patients with a certain HLA B35 antigen type. However, there have been no other real association with other HLA antigen type and red cell alloimmunization in sickle cell disease. There's been some associations, with antibody formation in either mouse models where the recipients have a specific HLA phenotype, or in other patients, but there's not been anything in sickle cell disease, and the HLA antigen types have only been specific to these blood groups. So it's not anything where we've been able to type people and figure out and say you're going to be at risk for sensitization. So one of the things that is important for us to do is to find a way to separate those who are going to be immune responders from those who are not going to respond and make antibodies after transfusion. So identification of genetic markers for patients that would be at high risk of sensitization would be useful. This would allow us to conserve the extended antigen matched red cells, which are actually expensive. We're charged for every antigen that we specially order on top of the cost of the red cell unit. So these can become units of blood that may cost, $1,500 to $2,000 per unit. We also need to take into consideration the potential need to do molecular matching, specifically for RH variants. There's molecular variation in the different RH antigens that may make some patients additionally sensitive to sensitization, or impose a alloimmunization risk. The other thing that may also be a factor here is ancestry, and not just the antigenic differences we see between donors and recipients, but when we use ancestry as an index for genetic background, this may allow for a better investigation of biologic risk factors. There have been haplotype studies of African population that have demonstrated greater population stratification than in non-African populations. In other words, greater genetic variation within African populations than between African populations and non-African populations. So some have tried to leverage these characteristics for studies of genetic diseases, particularly when there is a disease that has an extreme selection pressure, such as malaria, which is what we see in sickle cell disease. And there have been a number of diseases like prostate cancer, breast cancer, diabetic nephropathy, where the degree of genetic West African ancestry has been associated with a trend towards increasing disease. And what's interesting is that when you look at the African American population in the United States, from different areas, there's actually varying amounts of European genetic population when you look at people from different parts of the United States. And it varies from as little as 3.5% European genetic contribution and African Americans from Charleston, South Carolina, up to 35% from African Americans in Seattle, Washington. So we looked at this and the propensity for red cell alloimmunization, and we found that the greater the percentage of West African ancestry was associated with a increased likelihood of red cell alloimmunization after transfusion. And so this was a GWAS study. And so you can see, and I'm sorry, this is probably kind of small, but the blue dots are the patients that have no antibody. And as you go more towards the right side of the chart, that is a greater proportion of European ancestry. And the green dots are the patients that have antibody. And the left-hand side is a greater proportion of West African ancestry. The other interesting finding from the study is that we found the FYB gene. This is not, there's a red cell antigen called FYB, but it's not that gene. This is a gene that is a binding protein involved in platelet activation and expression of interleukin-2 that appeared to be associated with the increased likelihood of red cell alloimmunization. So there have been other studies, and the other groups are looking at genetic factors in patients with sickle cell disease that may lend towards an increased proclivity to sensitization. There are other groups also using mirroring models and looking at immune cells from patients with sickle cell disease for other clues as to what makes some people more likely to make antibodies after transfusion. My colleague, Karina Yazdan-Bakish at the New York Blood Center, this is from just a schema that she's provided that shows the yellow circles are potential therapeutic targets, therapeutic agents that we might be able to use based on current data that may help to ameliorate red cell sensitization in sickle cell patients, including cytokine blockade, IVIG, steroids, B cell depletion, treatment with rituximab. And so these are things that are actually being studied now that may help limit that. However, the one thing that we know overall that prevents alloimmunization is not exposing people to foreign antigens in the first place. So we can't match for all 400 blood group antigens that might be on the surface of a patient's red blood cells, but we can match for the ones that we know are most commonly patients are sensitized to, which are the RHC and E antigens and the CAL antigen. And the STOP study, again, was very informative here. The separate data analysis on alloimmunization was published in Transfusion in 2001, and they showed that the patients that were chronically transfused who had blood that was matched not just for ABO and D, but for the CE and CAL antigens, only 8% of them made new antibodies after transfusion. So because based on this and other studies, this has become essentially the standard of care for red cell transfusions for patients with sickle cell disease. However, this is very expensive. And based on Markov models, looking at the cost for this, if you look at the cost of matching for antibodies, but also prophylactic matching over a 10-year period, it costs anywhere between almost $400,000 to almost $800,000 to prevent a single alloimmunization event. If we used our protocol here, which is the CE-CAL matching and then the extended matching for some of the other antigens, once a patient becomes alloimmunized, over 10 years, it could cost $2 billion if we use this for all sickle cell patients on chronic transfusion in the United States. However, given the impact of alloimmunization, particularly with the relationship with shortened lifespan, that's not saying that this is not worth of it. It's still, however, important to identify what the difference between immune responders and non-immune responders are, particularly because of the cost, because if we can sort out patients that are not likely to make allo antibodies, we can give them more limited antigen matched red cells and save the $2,000 red cells for the patients that really need to be protected from sensitization. So we know the differences in frequency of antigen distribution between donors and patients, and it's important. More transfusion increases your risk, and that prophylactic antigen matching reduces the incidence from 50% down to 7 to 8%. We're not so certain about, even when you have ethnic similarity between the donor and recipient, why we still have higher rates of sensitization. This points to some other gene. The other thing that we're finding more recently is the manner of exposure. Chronic exchange seems to be less of a risk than simple transfusion. And also, what role does the recipient inflammatory state have on sensitization? And also, what about the products themselves? Alloimmunization has been associated with an older age of transfused red cells in patients with sickle cell disease. Patients in this study that received red cell products that were a median of 35 days old had a much higher hazard ratio of becoming alloimmunized compared to patients that got 7-day-old red cells. And we have shown in our studies that leukoreduction, so the removal of the donor white blood cells, was actually associated with a lower rate of alloimmunization compared to patients who got mostly non-leukoreduced red cells. And what's interesting in our study is we also didn't find an association between transfusion during inflammatory conditions and alloimmunization that's been seen in other studies. The manner of transfusion, simple versus automated red cell exchange, has also been examined in a few studies. And you can see here that the patients that got most of their transfusions through red cell exchange actually had a lower antibodies production per 100 units of red cells exposed compared to patients who got simple transfuse. So, and that's something that is currently a subject of study by some groups. So we know red cell products for patients with sickle cell disease need to be from donors who are hemoglobin S negative. People with sickle trait can donate blood, but we can't use their blood for people with sickle cell disease. We should give them at least Rh and Kel phenotype matched. Unless they're alloimmunized against other antigens, then we need to give them extended antigen matched. The blood should be leukoreduced. Generally, it doesn't need to be irradiated unless the patient is receiving a stem cell transplant or has an immune deficiency. And they should, of course, be less than 42 days out. So this is fine until we go to order the blood from our blood center. And we have a shortage of all donors. You may have heard in the news, we have a very serious blood shortage in the United States right now. For patients with sickle cell disease, we really need to recruit more African-American blood donors. In 2010, published data shows that only not quite 5% of all blood donors in the United States were Black. Black people make up about 13% of the population. There have been a number of strategies aimed at trying to recruit more Black blood donors through churches and various other community organizations. However, one thing that's been identified, particularly when you look at the larger blood collection organizations, is that first-time blood donors, we're not doing a good job at bringing in new and younger blood donors, and that the majority of blood donors are actually older people. So we need to do also a better job of converting younger donors to repeat donors. And this is true not just for Black donors, but for all donors. One of the studies that I participated in a while ago was a survey of households in Maryland. And when we asked a series of questions, like, have you ever donated blood? And a series of other questions looking at their relationship to the type of medical care they've received, or, encounters with the healthcare establishment, we found that women and Black participants and anyone that agreed with the statement that they were afraid of hospitals were actually much less likely to ever donate blood. And so just as with, any other blood donor, we know what we need to do. It's finding the best way to do it that inspires trust, is convenient for the donor. We need to educate people as to why we need continued regular blood donation to sustain our blood supply, and evaluate the services that are provided to donors. And I mentioned this already, we're in a severe blood shortage right now. This has been, unfortunately, a durable shortage. It's been really severe for the last 2 years. We've been way below our national inventory of blood, and this is largely compounded by the pandemic, where people just haven't been out in groups, but also because most blood is collected in workplace drives. So now with everybody working from home, we have fewer employment-based blood drives. So we've been really trying to get the message out to people that we really need folks to come out and donate blood, particularly during the summer, when we also typically see a reduction in our inventory. And that's because our regular donors go on vacation. And, so we just need to really emphasize that, particularly in the setting of the recent World Blood Donor Day, that this information to the getting the information out to the general public is critical. You can go to this website, aabb.org. They have a donation locator on their website that allows you to directly go and schedule your appointment. So in summary, red cell transfusion is an important therapy in sickle cell disease, but complications such as alloimmunization can limit availability, be life-threatening. These are mainly caused by antigenic differences between the donor and recipient, but there's also probably some genetic predisposition as well as component characteristics that warrant further study. Strategies to increase regular blood donation from all who are eligible, but especially for Black donors to support patients with sickle cell disease must be employed. So I have a limited amount of time to take questions, but I can take some questions now.
Yeah, I have just one for you that I think we can fit in with the time that we have. If you were to have 2 to 3 takeaways from all of this great information to share with not your parents, my gosh, well, your parents too, maybe, your patients, what would those be?
Information for patients here?
Yes.
Well, actually, the best information for patients with sickle cell disease is that they need to know their own alloimmunization status. So this is a particular point of difficulty for hospital blood banks because we don't share information. So my hospital is located in a place called the Illinois Medical District in Chicago. I'm across the street from Cook County and Rush Medical Center and the Jesse Brown VA Hospital. I have no access to Rush or Cook County's blood bank system. So if you're a patient who went to Cook County, got transfused and made an antibody, and you came to my hospital, I may not know about whatever happened at the outside hospital. So it's very important for patients to know that if they are one of these folks that require specially matched blood, some places mail out like little wallet-sized cards that tell people what their antibodies are. That's been a variable use to people because, you know, the cards get lost, you get a new wallet, you forget to put it in there, that sort of thing. There has also been work towards trying to establish at least a regional database of patients who have antibodies that can be shared through blood banks. But I think it's just enough for the patient to be told, look, if you go to a different hospital, and they tell you you're going to get transfused, tell them, call UIC or wherever it is that you get most of your care at, because their blood bank will have information. We are allowed, the HIPAA law does allow us to call other blood banks to get transfusion information on patients without having to sign consent forms and stuff because it's direct patient care. So that is something that we do allow. So that's the most important thing for patients, to know what your antibody status is in regards to transfusion.
That's fabulous. Thank you. Well, I would like to thank you once again, Dr. Campbell Lee, for joining us today. As just a quick reminder, if you would like to join the Partners Physician Academy 5-day training course this September 12th to 16th, please quickly check out the chat. For more information, you can visit partnersphysicianacademy.com. Again, that's partnersphysicianacademy.com with all of the info. Applications must be received by July 8th for consideration. Thank you again, Dr. Lee, and thank you to all of our individuals who have joined today on all of our streaming platforms. We appreciate your time, your expertise. If you would like to watch this recorded webinar and all of our other archived webinars, please note that this will be available on Friday, June 24th at hemophilia.org under the events tab. Thank you for joining us this afternoon and have a wonderful week.
Thank you, everyone. Bye.